smoking, hypertension, cardiovascular disease, diabetes, metabolic syndrome, obesity, vitamin D deficiency. All of these foretell a greater risk of developing COVID-19, and they are all more common in bipolar and other psychiatric disorders. Welcome to the Carlat Psychiatry Podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the Editor-in-Chief of the Carlat Psychiatry Report.
And I'm Kelly Newsom, a psychiatric NP and a dedicated reader of every issue. In this month's Carlat Report, we feature an interview with a pioneer of lithium research, Janusz Rybakowski. Like many bipolar specialists, Dr. Rybakowski believes that lithium is underutilized.
There is, of course, some kind of paradox or some kind of discrepancy. That from the one side, lithium is accepted as the first-line treatment and first-line mood stabilizer, and also, in my opinion, the second main indication, psychiatric indication for lithium is augmentation of antidepressants in treating resistant depression. I think that lithium is best for this purpose. Out of these bipolar patients, 1/3 can be called excellent lithium responders. And these excellent lithium responders are people, if we give them lithium, the illness is ceased. There is no illness at all. And also we have now evidence for anti-suicidal, of antiviral, immunomodulatory, and neuroprotective effect of lithium.
In the article, we have a useful table that highlights who is likely to respond to lithium, but lithium use is on the decline. Here's some new data from the USA. In the 1990s, 38% of bipolar patients took lithium, and today it's 14%. Lithium has held its ground better in countries with socialized medicine, where care is driven more by evidence-based edicts like the NICE guidelines than pharmaceutical dinner talks. But even there are signs of slippage. In Germany, lithium use in bipolar has declined in the last decade from 31 to 26%. Dr. Rybakowski speculated on the possible reasons why.
It's greatly underutilized. I think there are two main reasons. One is active and aggressive promotion of this new mood-stabilizing drugs. And the second is such a strange perception of lithium as a toxic drug.
You know, I shared those biases when I started practice 20 years ago. Back then, I thought of lithium as something toxic to the body and intolerable to the patient. But if we look at the raw numbers, patients generally tolerate lithium much better than the atypical antipsychotics. We reviewed that in our podcast on lithium side effects 2 weeks ago. And while high levels of lithium are toxic, and lithium does have medical risks like hypothyroidism, renal insufficiency, and cardiac arrhythmias, it also has medical benefits that are relevant to bipolar disorder. Those include lower risks of stroke, heart disease, including cardiac remodeling, cancer, and neurologic illnesses, including dementia. None of this data is definitive. Some of it is better than others and based on controlled trials like the dementia question. And most of it is fairly new data, just in the last decade.
But lithium also has antiviral properties, and that's actually old news. In 1970, lithium was found to disrupt the adenovirus in a laboratory study. And in 1973, it degraded the herpes simplex virus. The first human studies of lithium's antiviral activity date back to 1980, when they found that labial herpes infections went away when bipolar disorder was treated with lithium and returned when the lithium was taken away. Dr. Rybakowski was a key player in that line of research.
About this time, there were several case reports in very prestigious journals like Lancet of New England Journal of Medicine, where the authors described in the patients taking lithium that if they had some labial herpes infections, such infections disappeared completely. And generally, labial herpes, which is caused by herpes simplex type 1, is occurring in about 1/3 of the population and has frequent recurrences. So we did the retrospective study of labial herpes recurrences in patients receiving lithium. In our study, we had 28 patients on lithium Half of them, the labial herpes completely disappeared, and 1/4 significantly decreased.
So you saw a big reduction in labile herpes in patients treated with lithium. How did that compare to psychiatric patients with herpes who weren't on lithium?
With lithium, it was decreased by 73%. In antidepressants, there was no whatsoever. Also in Poland, we did a study with lithium succinate ointment, and we did it in 42 patients with labial herpes with very, very excellent results. Full recovery was obtained in all patients.
It's against the herpes virus that we have the best evidence for lithium. In fact, the only randomized controlled trials of lithium as an antiviral agent were done in herpes, and both of those studies, although positive, were small. In other viruses, lithium has positive results only in animal or petri dishes, or in human studies that were observational and uncontrolled. For example, patients have lower rates of the flu on lithium, but not on other psychotropics.
We, with J. Amsterdam, did some study on the rate of flu-like infection in patients which had psychotropic drugs. And we found that those which were receiving lithium, they had definitely reduction in this flu-like infection.
So, in the lab, lithium has successfully gone against over a dozen viruses, including DNA viruses like pseudorabies, vaccinia, measles, parvovirus, Epstein-Barr virus, and cytomegalovirus. But those are all DNA viruses, and today's coronavirus is an RNA virus. Lithium has also impeded the replication of RNA viruses, such as murine leukemia retrovirus, foot and mouth disease virus, HIV, feline calcivirus, mammalian orthoretrovirus, porcine diarrhea virus, and 4 viruses in the coronavirus family.
There was at least 4 kinds of coronaviruses where lithium was kind of beneficial, that it inhibits replication and inhibits apoptosis.
Does lithium treat the coronavirus?
We don't know if it does treat today's coronavirus, but there are half a dozen theoretical papers out there suggesting it might. One problem, though, with using lithium against the coronavirus is that it has risks of its own, particularly toxicity. Now, in the herpes research, they were able to suppress the herpes virus with blood levels similar to what we use in bipolar disorder, like 0.5 to 0.8. But there's also some evidence that higher levels, such as 1.2 serum level, might be necessary to really fight off a virus with lithium. And those levels, of course, are potentially toxic. So it's unlikely that lithium is going to be used against the coronavirus anytime soon.
Then why are we yapping about it in this podcast?
Well, there are at least 2 things you need to know about lithium and the coronavirus right now. The first has to do with patient education. People with mental illness often look on their meds as something they have to take, and that they're doing it at a cost to their physical health. So here's a situation where patients on a particular psych med, lithium, might be getting a benefit that no one else in the population gets. I find that helpful to share with patients so they get a different perspective on it, and it also reduces the stigma of taking it. And, besides these antiviral properties, which are direct on the virus's replication, lithium also improves immune function. It increases the neutrophil count as well as lymphocytes, leukocytes, and natural killer cells. Of course, a good night's sleep will do that as well. But this is also an important part of psychoeducation on lithium because patients on lithium usually have a high white blood count. And if their doctor isn't aware of that association, they might think the patient has an infection or even cancer when they see that benign elevation. The second reason to know about this is that you might consider lithium for a patient with bipolar disorder who actually tests positive for the coronavirus. But if you do so, you have to be careful because patients with the coronavirus or any viral infection are at greater risk for lithium toxicity. Last May, Drs. Suanwangsi and Shabarak in New York City reported on 2 patients who developed lithium toxicity as a result of COVID infection. Now, viral illnesses have long been known to increase the risk of lithium toxicity, mainly because of dehydration from fever, vomiting, diarrhea, and poor oral intake. Anti-inflammatory NSAID use during a fever adds to that risk by raising lithium levels. And COVID brings an additional risk because renal function can decline during severe COVID illness. So, if patients are going to take lithium, they need to keep hydrated, stay away from NSAIDs, and have their levels checked regularly if they develop a viral illness.
In case of fever about 39 degrees of Celsius, vomits, diarrhea, it is advisable to pause lithium for 1 to several days until given patient is able to return to the usual way of eating food and drinking.
That's disappointing that lithium isn't likely to be used against COVID. But are there other medications that do similar things that might fight the virus?
Yes, there are many meds in the anti-COVID pipeline, and at least one of them has lithium-like properties. That's Epsilon. Epsilon is an experimental drug that's being investigated for bipolar disorder as well as COVID-19. Like lithium, Epsilon dampens phosphodiesterase signaling by inhibiting inositol phosphate phosphatase. Epsilon also induces lithium-like behaviors in mice. It's right now being tested for COVID because it inhibits the main protease that COVID uses to replicate. That's called 3C protease. And surprisingly, alprazolam Xanax was also found to inhibit a COVID protease in the lab. But I don't think they're going to be testing alprazolam further because more suitable candidates for that effect were found, celecoxib and carbophren.
Celecoxib, the NSAID? I'd bet you'd want to avoid that with lithium.
Yes, you would. But as we reported this year in the online journal, celecoxib, the brand name Celebrex, is the anti-inflammatory with the best evidence in depression. Overall, it had a large effect size in controlled trials of both bipolar and unipolar depression. And in the journal, we go into more detail on how to use it and how to watch for particular risks with it. Since that article came out last year in the Carlott Report, there's also been a new study, and this one was in treatment-resistant bipolar depression. That's really hard to treat. They used celecoxib along with escitalopram Lexapro, and half the patients got celecoxib, half of them got placebo. Now, this was a small study, but in it, celecoxib worked surprisingly well for bipolar depression. It brought half the patients to full remission, and these were patients who had failed to respond to over 3 or 4 other medications.
And now for the word of the day, vitamin D deficiency.
Lots of psychiatrists are checking vitamin D because low levels of this vitamin have been associated with depression. And while that association is pretty well established, what's less clear is whether correcting the levels does anything to help depression. There's a few positive studies in seasonal depression, but also negative ones. And on the whole, the larger and well-done studies look negative. So how can that be possible? Well, it's probably that the deficiencies in vitamin D we're seeing are due in part to something else that goes along with depression, like obesity, advanced age, poor diet, lack of sunlight. Even taking some medications like carbamazepine can reduce vitamin D. Still, it's worthwhile to check vitamin D because these deficiencies are very common in psychiatric populations, and correcting them can lower the risk of bone disease, cancer, and, this is breaking news, COVID-19 infection. In fact, Dr. Anthony Fauci recently revealed that the 2 supplements he and his wife take to prevent COVID are vitamin D and vitamin C. Clearly, this is a big topic and we could do a whole podcast on it, but we're just going to end with the basics of how to assess and treat vitamin D deficiency. I've also put these numbers in the show notes. To order vitamin D, write for vitamin D 25-hydroxy, and insurance will often require a diagnostic code for that. It's E55.9. To interpret the level that comes back, you'll want that level to be between 30 and 60 nanograms per milliliter. There is some evidence of harms, like one study found increased mortality in the higher ranges beyond 60, so no need to go overboard with this, but there's no real definitive proof of harm. Now, 20 to 30, which you'll see a lot if you test this regularly, is just a mild low level, and it's hard to show much harm in that range, but still a good reason to supplement there. Once the level goes below 12 nanograms per milliliter, that's going to be grossly inadequate for bone health, and you'll definitely want to supplement. Here's how to correct vitamin D levels. You're going to use vitamin D3, and the patient can take it over the counter, like 2,000 international units daily for a mild deficiency in the 20 to 30 range. Or if it's more severe below that, you'd want to use 6,000 international units daily, or you can even give that as a prescription, a weekly prescription of 5,000 international units weekly, and that's all by mouth. The weekly one is often easier to take, and patients are more likely to stick with prescription medications. I often find that patients eventually fall off with taking the vitamin D. Many of them think that it was supposed to be a temporary fix when it's usually not. But it is a good idea to check up on the levels because they don't always rise. Obesity, malabsorption might prevent it from rising. And in those cases, you want to refer them to their primary care doctor for further care.
But how does vitamin D prevent COVID?
Vitamin D might prevent COVID-19 through regulating the renin-angiotensin system, which is part of how the infection propagates, or by modulating the immune system, which vitamin D does both of these things. And we have a handful of clinical studies showing that it does. In one, people with low vitamin D were 1.77 times more likely to contract COVID-19. And once they get COVID, people with low vitamin D are 20% more likely to die from the infection. Now, while those results are suggestive, just like with depression, we don't really know if they're causative. But unlike depression, we do have a confirmation study here from a small randomized controlled trial where they took 76 patients with COVID and randomized them to high-dose vitamin D. They used the active metabolite of vitamin D, which is 25-hydroxy vitamin D3. And here's what they found. Giving the vitamin D lowered the risk of going into the ICU from 50% on placebo to 2% on the vitamin D.
Join us next week for a look at how the pandemic is affecting the psychopathology of everyday life, the mental toll of quarantine. You can read the full articles and earn CME credits at thecarletreport.com, where we have a special offer for our podcast listeners. You can get $30 off your first year subscription with the promo code PODCAST.
The Carlat Report is one of few CME publications that depend entirely on subscriber support. Thank you for helping us stay free of commercial influence.